So I'm pleased to introduce...
Hold on. She's introducing me. You're talking. Yeah.
Thank you, Dr. Cifu. So I'm pleased to introduce Dr. David Cifu. Dr. Cifu is the chairman and professor of the Department of PM&R at Virginia Commonwealth University. He's a senior TBI specialist at the U.S. Department of Veterans Affairs and the director of sports sciences for the NHL Florida Panthers. And he'll be talking to us today about concussions and anything else we want to hear about.
Yeah. Thank you. I appreciate it. And the reason I'm wearing this outfit isn't because I'm really gung-ho sports medicine. It's the only thing warm I own right now because I'm spending a lot of time in Florida with the Panthers, and it's really hot there, so I get all my warm stuff. Well, my cold weather stuff is in Virginia, so I apologize. I'm not a sports kind of guy. But I'm going to talk about concussion. What? Yeah. Oh, we kicked your butt. It was awesome. You guys, yeah. You had a good first period, but then we crushed you in the second two. I'm gonna talk about concussions overall, everything from combat to civilian to sports. I can stop at any point and just talk about the NHL and sports medicine and that if you wish. I don't care. But I'm going to kind of get an overview. Interrupt at any time with any question. Lisa will argue about everything I say. So if you disagree with what I say, please yell at me. I'm totally cool. I'm going to put out some things which may be controversial. I don't think they're controversial. I believe in what I'm going to say fully. Everything I say actually has science behind it, as opposed to most of the people that believe in CTE and things like that. But we'll talk about it. So a lot of this is from my research. Oh, good. I know you don't. I know. A lot of it's going to be from my research and my clinical experience, but I'm going to also talk about what's in literature. So we're gonna kind of go through these things. You can all read. I may or may not cover these topics, but you always have to have goals, all right? These are some of the common myths that one of my goals in life is to dispel or to prove, but most likely dispel these things. The more I'm involved with sports medicine, the entire field of sports medicine needs to be debunked, which is one of my goals, particularly as it relates to brain injury, but also even MSK. So that's going to be my next slide in the future. All right, so there's lots of concussions. It depends what numbers you read. I don't know. We're American-centric, so for some reason we have to tell you the American number. So 3.8. I gave this talk in China. They told me it was like 10 million in China. Like they occur every 2 seconds in Beijing as you're watching it, at the door. So it's very common. This is the total number of TBIs, half of which go to the ER, half of which don't. Depending what numbers you believe, I don't believe the 80% of brain injuries are concussions. That doesn't make any sense to me at all. That's the number of folks use. So if you're taking your boards, that's kind of the right answer. It's got to be closer to 95%, just that they don't go to the emergency department. But the number is 80, and then it's like 15.5. But I don't think those numbers are accurate. But there's certainly well over 3 million concussions a year, and they've been occurring for the last, 3 million years, however long people have been upright. So concussions are extremely common. They recently doubled this number. It was 1.9 or 1.8 for a long time. And then the CDC got together and said, there's all this underreporting, both concussions that are occurring in civilians as well as falls in nursing homes that aren't being reported, which are resulting in subdurals or other injuries. So the number is fairly high. Here's the ED admissions. This war number is completely made up, and I did it, so I'm happy to have made that up. We have a very large screening program that, and I don't know if I asked Lisa for help, but there was a weekend in 2007, I think around April, that the VA said, we need a comprehensive, nationwide, actually international screening program for brain injuries, specifically concussions in the VA for all returning folks from Iraq and Afghanistan, because the military has one, even though they really didn't, and we need it by Monday. And so I called up Rod Vanderploeg, I asked my guys, I read everything I could in the literature, and so we came up with a screen over the weekend, and we implemented it in April, and it was validated sort of about 5 years later, thankfully, so we have the numbers, and it's 7.8% of all folks who return from Iraq and Afghanistan. I may have that slide later, but 8% of all folks have persistent symptoms that are felt related to a combat concussion. All right. Of all the folks that are in Iraq and Afghanistan, which is like 2.6 million, about 16 to 17% had a concussion that is documentable. So about 40% of those folks still have symptoms. Really high number of folks with persistent symptoms after concussion. As Lisa will tell you, because her research is better than mine, the majority of those symptoms are actually probably not related to the concussion, but rather the emotional stresses and the physical stresses of war and being in military theater and the post deployment issues they're having at home. But the numbers are somewhere around 250,000. If you say only only 1% of them are due to the actual combat concussion, you don't get funded. So if you say it's 250,000, you can sleep okay. If you really want to get a lot of funding, you say 400,000, like the PTSD people always do. You say it's really, really high. But so we don't really know the number, but 250,000 is the official number that's been published by me and others. But it's if you work in the VA system, you know how challenging it can be. I mean, the record I've seen is 151 concussions from combat. The average is about 4. If folks that have had 1, they've had 4. But it really is amazingly variable. And we'll talk a little bit about the research we're still doing. I think concussions are the easiest thing in the world to diagnose. I think it's hard to diagnose an MI. I think pneumonia is kind of subtle. I mean, I went to med school, I did all that kind of stuff, but there's all these tests, and you gotta look at x-rays, and, you gotta look at enzymes. But a concussion, all you have to do is talk to the person. All right? And we are absolutely horrendous at doing simple discussion. In the NHL, I'm watching the games, I'm behind the bench, wherever it is, and I see a guy unconscious on the ice, like out, right? He was in the other team, he was out, right? He got hit with a puck. Right, broke his helmet. This was like last week or something. He's like, is he dead? I don't know. He's there, right? So, the trainer goes out, and I'm looking. I'm like, I'm going to bet they're going to say he didn't get concussed. He was a star, right? So, he was fine, like in 12 seconds. He gets up. The trainer takes him off, right? And then he goes into the training room, the visitor's training room, and I send our FP sports medicine doc to go see if they need help. The trainer said he's fine. He was fine. All right, there's an NHL spotter system where they got guys, but the spotter didn't say anything because the trainer was right there. And I mean, Stevie Wonder would have diagnosed it based on the fact that the guy was, laying there, But that trainer said, the player said, I'm fine, didn't take him through the protocol, which is kind of embarrassing anyway. And he didn't play the rest of that game because he had a big laceration on his head and was bleeding. But he didn't go into the concussion protocol. And I don't think that trainer knew the concussion protocol, all right, which is the simple one is actually just asking the human being, did they have a traumatic event, or you witnessed it, but they have a traumatic event, and as a result of that traumatic event, was there an alteration or loss of consciousness? If you throw in there a little PTA, if you throw in there some memory loss, that ices it, but just asking them. And apparently this is very hard to do. I'm being a little facetious, obviously. I'm thinking we all know this, but in the systems that I've been working in, the military, the VA, as well as in the NHL, less so in the civilian sector that I've seen, but apparently that's hard to do, or that's not reliable. Whereas asking someone if they have like chest pain, is there an elephant sitting on your chest, somehow that's more reliable. Or does it hurt when you breathe? That's more reliable. And then getting an x-ray that shows, I don't know, some fuzziness, that's okay. But because we don't have that next phase test, other than, doing cognitive testing, not necessarily formalized neuropsych, just doing some simple cognitive testing, taking a symptom inventory, apparently that's not enough. So in terms of your tech transfer, I know some of the faculty, we're just at the faculty meeting, tech transfer, billion-dollar thing, billion-dollar idea, come up with a simple concussion test. All right, it's not possible, so it's never going to happen. But because there's about 20 of them or 30 of them out there. Impact is as close as folks have come, and Impact is horrendous. It is the gold standard, but it's horrendous. The King Devic, one of Lisa's favorite, is another one that's out there. Ooh, that concussion, you're right. All right, is another one that's out there. But we don't need a different test other than asking a human being how they're doing. And there's never going to be a blood biomarker. I bet someone 10 years ago from the DOD, 10 years ago, that I would give them a year of my salary versus theirs, and I made more because they were in the military, that there wouldn't be a biomarker in a year. It was Jeff Lang. I was the head of DARPA. All right? And Jeff said, oh, Dave, I can't take your money. It's like, Jeff, take my money. Trust me. You ain't going to do it. They were putting $600 million into biomarkers. And what do we have now? Nothing. Zero. They will not be a biomarker for a concussion, all right? And I'm one of the researchers who says we need to get one because they're paying me to do it, but it's not going to happen. So again, easy to diagnose, can be challenging, however, because in the face of a significant trauma, whether it's military, whether it's a car accident, even if it's on the ice or if it's in a football game, all right, the acute stress related to being hit that hard or seeing death or near death or hearing loud noises, whatever it is, can give you these same symptoms. Every symptom of a concussion, acute concussion, can also be manifest by acute anxiety disorder or by acute stress disorder. So it is very challenging. But that's why there's a little art to this, all right? And I don't think folks that do this frequently have a challenge with that, but apparently the rest of the world does. But it's good. It's good for job security. I'm not going to spend a lot of time on PCE because as if concussion weren't challenging enough for the world, there's the idea that some people have a different level somehow. I don't know why humans, somehow there's a different evolved species of humans that can take greater hits and get what should have been a concussion for the rest of the world, but they didn't really report any changes, all right? Whether you're measuring the impact force that's on their helmet, or whether you watch them blow up, but they kind of say, nah, I'm fine, Or in fact, the threshold was too low and they had no symptoms. They didn't have any problems. But there's a belief, mostly in the CTE world, the chronic traumatic encephalopathy world, that people are getting these subclinical injuries. It's like a Steve Martin joke, right? They're getting an injury so low, they have no symptoms, no idea that anything happened, but somehow their brain knows about it, all right? Folks at BU, who are my research partners, believe very heavily in this. If you've never heard Robert Stern lecture, he's awesome. I love him lecture. I think it's mostly BS, but I love listening to him. I almost believed in it. It was so good. But he's got data, which isn't published yet, that we've seen, that if you're a lineman in the NFL, just about every play you're getting a PCE. Just the force of 300 versus 300 pounds at 25 miles an hour, because that's how fast they can go within like 3 inches or something like that, just destroying each other, all right? It somehow gives you this thing, all right? It's interesting, but there's absolutely no animal data to support it. We really don't have any. Again, Bob Stern says he has some, but none that I've seen published, none that our folks in our different research labs can come up with. But this phenomenon is like just when you think concussion, you kind of got it. And I'm like, okay, if you get like 5,000 concussions and never get treated, and you got stress of life, yeah, I guess you could get demented from that. But this, I think they're talking about like 18,000 or 20,000 PCEs in the typical NFL player's life. So this is, I don't know what this is, but just so you've seen the term. All right, so essentially there's some force, but it's a sub-threshold, subclinical force, and they don't have any symptoms, but somehow it impacts them. I mean, the idea would be if you took your limb and you bang, I'm not going to do it. I did this at one lecture, I cut myself. So you're banging on something, right? And I'm not talking about like you're a carpenter really banging it. You're like just going like this, all right? And if you do that enough, it's causing something inside my knuckle or in my skin or I don't know, maybe my brain, that eventually will cause pathology if you do it enough times. It's interesting, cumulative trauma disorder, which is a little soft too. We don't really need more of this in our space. We have a lot of these kind of vague cumulative things. All right, but this is yet another one. So just so you've heard, oh, I'm dead. It's over. Shoot, I must have killed it. We're gonna talk about PC for the rest of the time now. Dead. Really? All right. I don't really need the slide. Oh, that worked. I got excited. Okay. Oh, I'm panicking. Hold on, which way is it going? All right, this way. All right, so helmets prevent skull fractures. It came out in the early 1900s. People were dying in college football. Teddy Roosevelt was somehow involved. I love Teddy Roosevelt. If you haven't seen the Roosevelts on Netflix, oh my God. One of the best documentaries I've ever seen. But Teddy Roosevelt just totally rocked. Somehow he was in this space. That he was like, people are dying in college from skull fractures, they're banging their heads, let's give them leather helmets, and so they died less, okay? But helmets, if anything, would increase the risk of concussion. Because concussions are caused by the deceleration, or rapid acceleration, deceleration, or by rotational movements. And the more there is to rotate, the heavier it is. And then stop, the higher the force is going to be. So if you've got a big head, all right, like if you're an elephant, all right, and you move really fast, you're playing football, that head's going to keep moving and move rapidly. Now, elephant's too big, but if you're a fast animal with a big head, all right. So this just makes your head bigger and makes your head have greater velocity or acceleration. So helmets only keep you alive, which is good. Like, you know, there's no motorcycle law here. We saw it on the way. It's fantastic, great for rehab business. So you're going to get much fewer concussions, which is great, and more like moderate severes, which is which I enjoy taking care of more. But you know, in the sports arena, the helmets are designed to prevent skull fractures and facial injuries. But if anything, they're going to make the risk of concussions higher. They're not going to do anything to prevent. Even, you know, in the old days, not the old days, probably 20 years ago, they would put neck supports and strap the neck to the body like this. In the military, they tried that too, and they realized that people can't really play sports like this or kill people. Plus, they were getting neck injuries like crazy, and it did nothing to reduce concussions. You know, so you know, this is, you know, it's 8 pounds, whatever it is, it's moving. It really needs to keep moving. You know, the only helmet that would work would be one that weighed 5,000 pounds, so it wouldn't allow much movement, or one that was giant and fluffy. All right, so you just kind of bounce like those big sumo suits. Wouldn't be much of a game. Be kind of cool to watch, you know. Or if they had helmet airbags. Have you guys seen the bicycle airbags? Those are rocking. I think the Swedish, Norwegian, someone came up with them. They're kind of cool. It would ruin most of professional sports, though, because after each play, everybody would need a new helmet, you know, and start over. And you see all these bags floating and stuff. Wouldn't do much. Interestingly, in hockey, the helmets are extremely thin and barely prevent skull fractures. And the reason isn't because the owners won't pay for it. My brother owns the Florida Panthers. That's why I work for them. He's forced me to do this. And he'll buy any helmet I want him to. Or the players want to. The players want to look good. They want a light helmet that makes their hair look good. Aaron Ekblad, our star defenseman, has the best hair in hockey. And he wants the helmet. They told me this. They really want it to look good. So their helmets barely even prevent injury. Nick Bustad was one of our great players, too. Nick got a fist to his helmet last year. Went right through the plexiglass. And a massive cut on his head. I mean, this is a helmet. The guy barefisted just punched right through it, and Nick was so psyched. He's like, "I'm a warrior." But you know, so the helmets really are doing very little in the NHL, but in the NFL, obviously they're doing a lot. But they're really preventing facial injuries. But there's no evidence that they have any effect on concussions, and theoretically they should make them worse. The reason folks stay out for a week after playing sports is obviously it's biblical. We love that, you know, in this country. It's the time between NFL games and, you know, NCAA games or football. We like that. And because this data from 1980s from Dave Havda on his rats showed that, well, in about a week, the numbers come down. All right? This is neurotransmitter abnormalities. So he's like, well, I stole this from Dave. Dave said, yeah, you know, the folks in the NFL called me 25 years ago. The sports medicine world called me. And they said, do you have any data on how long someone has to be out? All right. And he said, well, I work in rats, you know. And he said, this is my rat data. And they said, perfect. That's exactly good, right? So this is exactly how long it takes a rat sort of getting better. Now, rats, you can't even tell. I mean, rats don't have interpersonal issues and irritability. And they rarely complain of headaches, so we don't actually know how symptomatic a rat is. And it's really hard to get a four-legged creature imbalanced. I mean, they're walking on like a thread, you know. And so you know, we don't have a great balance test. We have some tests, and obviously the tests are largely for cognition and learning, et cetera. But we know they're neurotransmitters. So this is where they got the number originally, the NFL. All right. There's no data that says 7 days, or the NFL, the sports world. There's no data that says 7 days is magical. And I'm going to probably allude to, but then maybe go into more depth how long I believe people should be out. So, you know, the person on the right here, or yeah, my left, your right, got pretty bad DAI, so bad that it affected their brainstem and they died. All right, that's not, that, by definition, this is not a concussion. You know, it's challenging to show images of concussions because less than 5%, probably even less than that, of folks will ever have any abnormalities on imaging. If there are imaging people here, I apologize for this, but imaging people think they can see everything, and if it's not enough T, they'll add more T's, or they'll add extra acronyms, you know, DTI, we got, you know, SWT, you know, and reality, you don't use imaging for concussions. I don't even use it for late concussions. I know people do. People are like, well, they're slow to recover. Therefore, I'm going to get an image. Why? I don't understand. What's the logic? Well, because I might find something. What might you find? Like, okay, what if you found this? Well, this is obviously early. You've got some petechial hemorrhaging. You know, there's a lot of petechial hemorrhaging. But let's assume you saw this late. You might see a hole. You might see a vacuole. What am I going to do differently? Am I going to somehow make a diagnosis? No. Is it going to affect my treatment? No. So I try not to order any MRI ever. That doesn't mean I don't. I just take an ultrasound probe and pretend I can see things. Now, it looks good. You know, but yeah, we get MRs. Yeah, we do. But really, clinically, there isn't a reason. Now, if you're worried about some other pathology, I get that. But I'm not sure what other pathology kind of causes vague symptoms that persist for 6 months, that don't really get worse unless they get stressed. But if there is one, that's fine. But just understand, if you do see something, be prepared to tell the patient, so what? You know, I got that just to make sure there wasn't something else. Yeah, I saw a little something, but that has nothing to do with your prognosis. Because there are a suggestion of articles which are predominantly written by imaging folks. Bless them, but clinically relevant, not so much. But that talk about how, well, if you have a greater load of abnormalities, particularly acutely, then you're going to have a worse prognosis of 6 months. Really soft science. And I don't think we need to perpetuate that. You know, we're doing some research now. The folks in the NCAA and Tom McAllister out of Indiana are doing a big acute concussion study to look and see if there really is any association between early imaging, all right, and short and long-term outcomes of concussion. Right now, there's nothing. And let's not perpetuate that. And when there is, we can say it. Right? The one on the right, there's definitely a correlation. Death. Brainstem, death. I'm going the wrong way, see? I panicked. All right. No one, I don't know. So I don't know. Probably somebody knows. I have no idea how many folks have persistent symptoms after concussion. I know what the literature tells me. 90% of people are going to have some headaches. That's really high. I've had 6 concussions, obviously, right? 6 concussions. I was a terrible athlete, absolutely, and a spaz, you know? Terrible athlete. I did it for the cheerleaders. Terrible, terrible athlete. But, you know, I never had a headache, all right? You know, so I guess I wasn't the 90%. So we don't know that number either, all right? There are increasing studies that are, you know, certainly the folks have headaches first, dizziness next. All right, then they're going to have some difficulty with sleep, and then they're going to have some cognitive issues. But you know, these are things that occur very commonly in the typical population. People that have a stress of having a significant injury, even if it isn't one, or are kept out of play, or in a car accident, are going to have some of these symptoms anyway. But you know, the numbers are also vague in terms of when do they start to get well, and you know, how many folks still have symptoms at 3 months, which used to be called post-concussive syndrome. Nobody uses that term anymore, except people that are very gauche, all right? Now you say, just ready for this? Persistent symptoms after concussion. Somehow that's better. But a syndrome gives the implication that there's actually something bringing this all together, that the concussion somehow is causing all this, or there's some linkage, when in fact we know there are so many other factors. Not sleeping causes all of the symptoms that people claim to be part of concussion. Now, it could be that the concussion did cause the difficulty with sleeping because of anxiety related to the trauma, or because of headache, or because of some weird insomnia place in the brain we haven't found yet that was injured, all right? But, you know, to put that all together into a syndrome is not ideal for the patient. It's terrible for clinicians. So please don't use that term. Don't think like that. They may, in fact, have some persistent symptoms after the concussion. And the treatment's going to be the same as if they didn't have a concussion. You're going to treat those symptoms aggressively, like as you would. All right, and we'll talk a little bit about, or a lot about that. But in terms of the syndrome, you know, the numbers seem really high. How many folks deal with concussion here somewhat regularly? Do you deal with acute, chronic, with just subacute? Right, that's rehab, right? I love it. Yeah. Well, are you seeing 30? Well, the thing is, I was at a lecture at the AAPMR 2 years ago, and this fellow, God bless him, you know, said, 90% of more than 90% of the people had persistent symptoms. And I said, where do you work? He goes, he worked in a concussion clinic. I said, well, don't you think that's because they're all coming back? He goes, I don't know, but that's the number I always tell everybody. I said, no, dude, it's like 3% of people actually have long-term difficulties. 90% of people in your clinic are going to have those difficulties. But are you seeing 30% of people at 3 months still having symptoms? I mean, again, you have a biased sample, right?
Well, I have a biased sample.
Yeah, everybody come.
It's a workers' comp.
Yeah. Oh.
And it's a high-risk population, lots of.
Yeah.
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 So, yes, and.
In the NHL, it's like 1%. But and their workers' comp when they get injured, but it's a different bias. So we don't know that number. All right. Let's just say 15% between friends, and let's say 3 to 5% of the year because that sounds good. No, there's really not science yet. The best literature is 3 to 5%. The best literature is 15 to 30%. For some reason, I don't know why this is, but in the military, the 12-month number is 15%. I don't know where they get that from, but that's what Lou French lectures on, other people lecture on. So, the reality is we don't know these answers yet. Hopefully, some of the work that I'm doing and certainly some of the work that Tom McAllis is doing will start to give us some idea of a large population to look at it. These are probably good numbers to answer a patient quickly. Again, vague numbers. I have no idea what they mean. No idea why people would still have difficulties at 6 weeks or from a post or subacute standpoint, right? In my belief system now, it's 92.4% musculoskeletal, and what's left? Let's just say 10%. 10% psychological, because I haven't found I found almost anybody that I'm concerned that there's something inside their brain that is still causing problems at 3 months. All right, and that's both in my clinical, my civilian practice as well as the NHL practice. Well, I think I have the world's best physical therapist ever known, who is getting people with dizziness and headaches and insomnia after concussions better in like 2 sessions. It's insane. I mean, these are mostly acute, but we also have a couple players who, before my brother bought the team, had lots of injuries and just had athletic trainers taking care of everything, which is absurd, which is how the NHL works, who have chronic issues related to concussion and multiple trauma. And they were having a lot of facial asymmetry, lots of headaches, dizziness they never told anybody about. They all have some cognitive issues, but hockey players don't. Canadian hockey players go to Canadian high school. They learn how to say A. They're the nicest human beings ever, but they don't learn. I don't think they know how to read. These guys are intelligent human beings. They don't read books, any of them. The Canadians. The Americans go to college because they get scholarships. But in Canada, the cool thing is you go to someplace where the Eskimos are, you go to a Canadian high school and you'll play hockey for 4 to 5 hours a day. All right? And I don't think they learn much. So I don't know what their cognitive issues are, because they play video games and hockey. And they're amazing at both. That and soccer. They're amazing. But it's hard to assess their cognition. They don't, we have one of our guys didn't know you had to get your car re-registered every year. He says, oh, isn't that once enough? I said, really? Like, how long have you been living on the earth? It's like his 4th year drives as my parents did that. Or, these guys they rent every month. It has to be set up for them. They're not dumb. They're naive. All right? The Americans are a little better. The Russians, you don't talk to them. But anyway, we don't know why, if someone has an injury that's bordering on a moderate, they've got a blood low, they've got, some persistent abnormalities that have been there the whole time. Okay, I get the deficits, but the 95 to 99% of folks who really have a transient abnormality, it's there for maybe 24 hours if they were a mouse and we could kill them, and these folks have tons of difficulty with headache and dizziness still, but it's all cervical, all right? And I don't believe in injections. I don't believe in what we do in the world of spine care. I do believe in MSK approach to management with a qualified clinician providing that care. Could be a PT, could be an MD, that's fine. I don't believe in chiros too much. We have a fantastic chiro. He's got to be on anabolic steroids. I've never seen a 60-year-old man this huge. The patients love him. He carries his own table with him. It's got to weigh 200 pounds. And he sits there. And I was like, okay, we're trying to get these muscles back. And he's like, vroom, that rapid thing. It's like, this is insane. Why are we letting him do this? But the patients love it. All right. I believe very strongly that the treatment The cause is MSK. Certainly when it's chronic, clearly there's a lot of psychological persistent difficulties. They've learned to have these difficulties. We haven't treated. I don't blame the patients, whether it's workers' comp, whether it's a vet, anybody. We as clinicians have failed them. All right, and I'm as big a failure as anybody. All right, we really need to early on get folks mobilized. And I'm going to get into that in terms of how quickly they should rest, if at all, and what mobilization. If we keep telling our patients, just go and, let's assume you believe like me that you shouldn't rest at all after a concussion. You should go back to school and back to play and all that as long as it's safe. And really, other than playing professional sports, it's pretty safe. But even if you do that, if you just tell them to go be active. Tell little Johnny for the first week the tests don't count, and I'll drive him on the bus. I'll drive him if the bus is too loud or he gets dizzy, fine. But let's assume we're reactivating, we're believing the Canadian literature and all the increasing literature that says early activation is the key. All right? If you're not also monitoring and more so getting them to a clinician that can manage their MSK problems, even if they don't report them, all right away to you, then you're missing the boat. All right? If you are great, and I don't know how many physicians are, I don't know if you see people back 3 days after a concussion. You're not, right? You're seeing them subacute anyway. But even if you work you work with primary care or you're in a sports center, we've got a sports center, we're seeing them, either on the field when they come in, we're still not seeing them back for about 2 weeks. All right? If you're not doing well, give us a call. No. If they're not doing well in 2 days, they need to be getting interventions. All right? And I know it may be expensive, but you're gonna have patients without problems, without cognitive deficits if you get them early activated and get them into it, get with a good clinician. You may be that good clinician. You may have MSK skills and can do it. I'm fine. I don't care who's doing it. I believe in physical therapists as well. I love psychologists. I know there's only a few here. There was a Rob, my favorite people in the world. Great physical therapists are up there too. I like PM&R docs too. Anyway, so the chronic stuff, I'm thinking it's 93.2% iatrogenic. Or 100%, and clearly, look at that. That was cool. Psychological, I think we're creating that. All right. So huge fan of early aggressive intervention. Now, if they don't see you at all, then they can end up in our clinic. All right. And in which case, they're going to be a little bit more hardened. They're going to have, on the NSI, they're going to, the neurobehavioral symptom inventory, they're going to have 11 abnormalities, and you're going to be overwhelmed. But that's the kind of person that you need to tackle one symptom at a time, but also get them into an MSK based program. And I would not have said that 3 years ago. All right, I was doing that. Well, let's just wait, and we're going to treat one symptom, and you'll be better, and here's a note, and take it slow. It really doesn't work. And increasing literature suggests that that's not the right approach. Tons of anecdotal reports in the sports world. There's not a reliable, somewhat longitudinal study. All right, there's the 2 articles that have come out in the last 2 years about early return to exercise in children as well as in teens and young adults, which has clearly shown early physical activity, early meaning 1 to 2 days after injury, has a better outcome than late physical activity, which is 3 to 5 days. So we're not talking about 3 to 5 weeks, 1 to 2 days. Hockey players, 0 days. And the Panthers, the next day, they're in the gym, all right? And we're working on them, all right? And yes, they have very big contracts. We can do that. But very early activation. But again, this is so anecdotal. I guess it's been 6 months now, I was in front of the Senate or the House or somebody, and was somewhat controversial because I said, this stuff's made up. All right, I know, Mr. Representative, that your daughter, I don't know if you guys saw it on ESPN. Oh, no, what's CNN? Like, this guy's like swearing that he knows everything about it. He's like freaking representative from someplace. I don't know where the hell he's from. He's like, well, my daughter, when she was 14, had a concussion, and thank God they saw a neurologist who kept her out of sports forever. That was his thing. And he was so happy. Because otherwise she'd be like, brain dead now. I don't know what the hell she'd be. And I said, sir, I wasn't this meek, so I never am. But I said, sir, that's completely wrong. Okay? What he did was completely wrong, and is the worst thing that could ever happen to your daughter. He was like pissed at me, right? But then he asked the panel, does anybody else agree with Dr. Cifu? And thankfully everybody raised their hand. They just didn't have the huevos to kind of say it. I'm like, are you kidding me? Like we need early activation. But, beforehand, these guys were quoting all these numbers about how women have girls have more symptoms than boys. And then he was saying it's hormonal. And then he was saying, well, then their bodies aren't ready for the sport. Or I'm like, you have no idea. And I like it. Jerry Goy's a great guy, but he was kind of talking about that. I'm like, that's not science yet. There's some interesting anecdotes that might support that, but we shouldn't be putting that to our Congress, God forbid, all right, or to the world. Let's hold back, because I don't think we've evolved as humans so that there's a gender-related difference in concussion recovery at age 14. It just doesn't seem like our species would evolve that way. Our bodies aren't that different. I get the hormone thing. I'm not an idiot. I get it, all right, and I know the rat thing. What's the thing that they were trying to? What was the study? What was the progesterone study that failed? The last one, $15 million because they said that the folks said that. Well, Lisa, what's it? I'll think. What? Yeah, I know. Yeah, but it came out of Emory and stuff, and they noticed that female rats were doing better than male rats when bonked on the head. So they said, oh, we're going to look at it in humans, and so they looked at it in humans at Grady ER, and they looked at an N of 100, and they said, oh, the females did better than the males the males did better when we gave them some progesterone. All right, so they said, we're going to now spend $15 million, NIH did, and we're going to give mostly men, we're going to give all men, we're going to give them progesterone, but we're not going to give it to them by the cheap and easy to use patch, because you can't make money off that. We're going to give it to them with some weird injection thing that someone's got a patent on. We're gonna do it for 3 years, and we're gonna have 50 centers involved. We were involved, and what do you think it showed? Nothing. No difference. They had a propensity for rats. No, nothing happened. Nothing. There's no hormonal difference. All right. Now they're studying it in Europe because somehow Americans wouldn't have done as well. Ridiculous. So anyway, just interesting stuff. All anecdotes. All right? So, that's why when we see a consensus statement, that's what it is. And that's great. But the consensus isn't necessarily by folks that have a valence on the entire area. These are folks that have a belief system of how they're doing it, and that's the way it's just 7 days. And if you have 2 of them, somehow it's 14 days. Why is that? Why wouldn't it be 8 or 22? It's always a week thing, right? Anyway, so we don't know the answer to that. All right. Really, it's interesting. It might be right to keep people out for a week. I don't understand that. Why a week? Because if you do the conversion, and this is make-believe, but if you do a conversion between rats and people, I've asked a lot of basic scientists, and they'll never tell me this one, but a couple of them I squeezed it out of them. They said, well, in general, it's a 3 or 4 to 1 ratio. So meaning if it takes a rat a week, a human's 4 weeks. All right, and again, totally made up, but a couple of them told me that. I said, well, yeah, that's about right. All right, and so that would mean, based on Hovda's data, that we have to wait a month, all right, before the neurotransmitters would get better. Now, we can't do the neurotransmitter study in humans, although actually they're doing it at they're doing it at the Puget Sound VA. They're doing LPs on people with concussions, chronic concussions, right? But nobody in their right mind, literally, is going to do an LP on an acute concussion so we can look at, or even put a bolt in and look at CSF so we can look at neurotransmitter levels, all right? But they did it on rats, so we're never going to be able to do this study, all right? But if you believe what exists in the animal world, it's a week in a rat, and so therefore it would be 4 weeks. Now, we're not doing that. So if we're not going to take that, if we're not going to do a conversion, to just take a week for a rat and say that's the point of time when they can go back to play, to me is kind of inane. All right, but that's what we do, and it's fine, whatever. In hockey, we don't really use that because there's only like 2 days between each game, so they've never used that. They just what they say is when they're symptom-free, which I have a thing against, and then when they can pass their baseline testing. Everybody gets baseline tested on the SCAT-3 and on the impact and other things. Then they can go back to play. Every hockey player can tell you the impact answers without the test in front of them. They can. They're amazing. They can't pay their rent, but they even tell me. We had a guy last year who left the league because he thought he was developing CTE. Even he couldn't remember anything, but he knew the answer to the impact. It was amazing. And the SCAT-3, which is a make-believe, but combination kind of test of physical and cognitive, they get them all. I can't pass the SCAT-3. These guys are like bloody, no teeth, and like, oh yeah, SCAT-3, and they can, there is no right answer. I'm okay with the current consensus because it's safe. I do think, however, that, as I mentioned, early return to school and activity. All right, the kid's going to throw up. That's probably don't want him in school. But other than that, we're getting him there. All right, I don't care about the test. Life isn't about tests. But having him take the test isn't the worst thing in the world. Life hasn't ended because you can't spell, I don't know, Gallipoli in the 5th grade. I think we'll be okay in life, But an early return and symptoms, as I said, I don't see that these symptoms are due to something within the brain. All right, I think they're MSK. So why can't they go back to play? If they have a knee injury, we don't hold them out until their knee is perfect. None of these guys' bodies are perfect in sports or in the military. They're all aching. So you can't go back to killing someone unless your knee is perfect, but what your neck pain is preventing it. Now, the key is, can they perform that duty in a safe way? Can they play hockey in a safe way? Can they be a service member? I get that. Can they go back to school on the bus? I get that. We're not cruel to people. But in terms of waiting until all those symptoms are gone, they're just going to start telling us, which they do already, that their symptoms are gone. And if the symptoms are not due to something inside the brain, and I don't have a crystal ball, I can't tell you if it's due to inside the brain. I'm putting my money on it's not inside the brain. All right. Now, if they've got profound, persistent memory deficits, we're not talking about a concussion. If they have so much dizziness that they fall over, I'm down with that. But that's really rare. All right. And the vast majority of the imbalance that I'm seeing is MSK. All right. And if it's not getting better with MSK work, all right, then fine. I'll go what's inside the brain. The treatment's the same. All right. My return to activity with vestibular dysfunction is the same, whether it's due to, in fact, to labyrinthian concussion or whether it's due to MSK issues, because they get well really quickly. All right. But, just be aware, it's unclear what this information really means. And yes, you do need to be able to do basic things first, and you have to be at a scrimmage level, or, if you're in the military, you have to perform your duties, before you're going to do anything more than that. But assuming you're able to perform the activity, and the majority of professional athletes can play hockey within 15 minutes or less after getting a concussion. These guys are machines. All right? They're unbelievable. Like you can't test them. We have all these preseason tests. I'm like, how do you do that? They're like jumping halfway across the gym and stuff, and we're going to test them by some mortal test. It doesn't make sense. But anyway, so, we use the NHL guidelines, which don't have specific days of the week. It's when you're able to perform at the level. And we've got coaches that assess that, and also our trainers are assessing them on the ice to make sure they can do the activity. All right. I'm going to zip through I'm going to get to CTE. I'm not going to talk about the military stuff. Military is, that one I'm definitely not talking about. All right. Neuroimaging, cool pictures. No value clinically to me. As an experienced clinician, I don't know what to do with them. As a researcher, love it. Love the Einstein hair thing. I love functional anisotropy. I love it. It's so cool. And we're doing research, as many other people, in all this. Again, I'm pretty much willing to bet a year's of my salary, which has gone up recently. All right. To anybody here that we're not going to find something of functional use in the next year. That's an easy bet. I don't know if I'd go 5 years. I might. All right. It's cool. And we're spending like $4 million a year out of our research center to look for it. But DTI is the gold standard. Doesn't mean it's the best one. It's right now it's the gold standard. Diffusion tensor imaging, which is able to look at white matter tracks, and you can convert this into FA pretty easily. And it looks real pretty. It's very pretty. It would hang up in your office nicely. Don't know what these little blocks mean. All right. Walt Schneider at UPMC believes his functional anisotropy, which he can track every little white matter track. He can see a little, one axon is wrong. He can find it. And he believes that somehow that means something. Like, Walt, this guy looks normal to me, and you found abnormalities. Or this guy is completely abnormal and your FA doesn't help. He goes, well, it's big samples. So individually we can't use it. From a research standpoint, we're getting there, but not very quickly. The other ones we don't use. PET scan, no use whatsoever. Tau PET, $20,000 a pop. Tau PET, so we're getting to CT now. We're going to finish with CT. Tau is a protein that's in the central nervous system. It's a breakdown protein. Right now, because I'm doing a lot of high-level thinking, my tau levels are high. All right, my brain's working really hard, 200 calories an hour. I'm full of tau right now. And my body's going to hopefully clean that up, unless I drink a lot tonight. So I'm going to clean that out, all right? So there's always tau in your brains. The issue is, the belief is that people that get repeated injuries to their brain or have other abnormalities that don't allow that processing to occur are going to get a buildup of this end product. The tau itself is probably not causing the abnormality, but it's a marker for that. So, you know, the imager said, hey, we can get a radioisotope of tau, and we can do a PET scan and see who's got a lot of tau. All right? And so the folks at UCLA said, this is fantastic. We're going to predict who's going to get CTE. And who's the guy? It wasn't Emmett Smith. Who was it? Wasn't Calvin? It's Tony Dorsett. Of course, Tony went in there. Tony got rapped about 15,000 times, right? Tony's like, yeah, all right, sure. So Tony had a lot of tau. And I think Tony thinks a lot. I don't know. Tony had a lot of tau. And he was worried. He's got a 1/3 chance. Totally made up. And the FDA said, all right, enough. You can't do this anymore. This is make-believe. They shut him down. All right? Unclear what to do with this. But we were going to do research on this, you know, and it was $20,000 for each patient to do one tau scan. You know, we can't get a baseline. So even though I have a lot of research dollars, I said, I'm not spending that much money. I'm going to give it to Lisa instead, all right? So, you know, PET is interesting. It's suggestive, but right now there's nothing there. The biomarkers have already said, we got nothing. You know, if I were to collapse right now and my brain, this is sick, I'm sorry, my brains came out because I broke my skull, all right, there isn't a biomarker in my blood that could tell you that happened. Really, that's how good we are, all right? You know, we could say, well, probably something happened to him, you know? Really, you know? So there's a list here, and the hot one now is ubiquitin carboxy terminal hydrolase isoenzyme, which is UCHI or UCHL. That's kind of hot, and the other one is the S100B. But it's really, I mean, we can't even, and we're talking about looking for long-term problems from concussions. We can't find acute, moderate, or severes with these things. Now, we're just starting to get a hint. There was that nice article that said, well, we can kind of see acutes, not concussions, acute, mod, severes. All right? So, and they can kind of predict it as well as an acute CT scan. But are they, you know, so if there's blood on a CT scan, this thing would light up. You know, it's a little soft. You know, it's not quite ready. 5 years minimum for acute, moderate, severes. All right? I made that number up, but it sounded good, right? 5 years, probably. But for chronic miles, never. Can't happen. Absurd. For acute concussions, probably never going to happen. But again, think of me dead. Probably somebody wish dead, right, or almost dead there. You'd have to use your acumen as clinicians to determine that I had a brain injury, because you couldn't use this. An image would show up. All right. CTE, all right, does CTE, you know, if you have enough brain trauma, will you be at elevated risk for degeneration? Sure. Come on. I mean, you know, even I would admit that. If I bang this knuckle enough times there, all right, hard enough, in 5 years, whatever, I'm going to have some arthritis. We know that, all right? We don't know how many is enough. We don't know, you know, what intensity they have to be. We don't know, you know, what's the recovery point, you know, all that kind of thing. But, yeah, I believe football players get CTE, sure. They get 3,000 to 8,000 concussions in their entire playing career. And they get treated for 4 of them near the end. All right? I mean, you know, this is, you know, common sense. Yes. But that's like 0.001% of our population. All right? And this is a, you know, big epidemic. You know, obesity, not so much. You know, this is a big deal. You know, now, are there other factors that play into that? Of course. Are there epigenetics? Is there stress? You wouldn't believe the stress level in professional athletes. Maybe you would. I mean, even the guys with long contracts are so stressed. When they're not playing, stressed out the wazoo. And they have no outlets other than video games. They don't read. They don't go to museums. I'm not kidding. We're actually doing art with our guys. We're having them paint. We're doing drum circles. We're trying to do anything to decrease their stress. Even though their stress is, you know, they're Canadian, so they say A twice, they're stressed. But, you know, we're also measuring stress. We're measuring sleep. All right, but clearly it's not just the concussions, because not everyone's getting it. But, you know, the movie Concussion was terrible. All right, Will Smith was rocking, right? I lectured with Amalo. He's a nice guy. He's a little out of touch with the world. A little out of touch with reality. You know, he believes there should be a neuropathologist in every brain injury center. It's like, really, Bennett, they're alive, babe. But so, there's something there, but it's more than just the multiple hits, Hockey players are going to have a very low incidence. There just aren't that many concussions. All right. Yes, they occur. All right. But they would get it from stress perhaps, but not from concussions. But football for sure. If you haven't read League of Denial, the book that Concussion was really based on, not the other, it's fantastic. It really traces how CTE became this kind of worldwide epidemic, which it really isn't. You need more than 6, I'm hoping. All right, but probably thousands qualifies you to be at elevated risk to get something that's going to cause degeneration. And is it really degeneration, or is it after 5,000 concussions without good care and with ongoing stress, and you drank them maybe a little too much, let's just say, you're eating nothing but steaks and nasty things, and your arteries are clogged up and stuff. Let's just say after 10 years or 15 years, so maybe you're 50 years old, 52, 55, whatever it is, you get all that going on, you finally reach your vascular endpoint. So you've got a brain that's 20% compromised by tau, and then all of a sudden, that last 12, 15-ounce steak that you just munched on clogged you up. So you lost one more, fragment of a brain cell. You began to appear cognitively impaired. They weren't that high level before. They have a lot of anger issues, football players and some hockey players, that they have they're at high risk for mental illness, depression, certainly anxiety we've already talked about. Those things together. But I really don't think it's somehow this inflammatory cascade, which is what everybody's talking about. There's what inflammation? What kind of a body do they think we have? All right, I think it's a static phenomenon that then over time they develop vasculopathy. Or they drink, or they have mental illness, and that fire is burning inside them. So I don't think we're going to see someone who's otherwise in pristine health. I'm looking at myself, hopefully. Pristine health, who's had 6 concussions. I think I'm static. Whatever tau's in there is there. I'm getting a scan later tonight. But what we need to do is say, okay, you've had these issues. How do we prevent these issues? How do we manage your mental health? How do we work on your diet finally? How do we work on exercise? How do we do mindfulness? It's X, Y, and Z. So, I think that's what we're going to see. There are, of course, there are pathways. If you get one severe brain injury and you don't have a great recovery, you're going to be at elevated risk to get dementia eventually because you may have had a risk for dementia. Now you've got less of your brain working. That's been demonstrated. It's not common, but it certainly occurs. If you get a couple of, boxers are getting what's the goal of boxing? To cause a concussion. That's how you win the round. That's how you win the fight, right? If it's a good enough concussion, you win the whole fight. If it's a TKO. You want to knock them down. It's a concussion every time they fight. That's the goal. Multiple. In sparring, that's all they do. And often, if you look at images of boxers, they've got a lot of abnormalities, which look like they've had repeated subdurals. They've even had some, they've had actual, bleeds in their heads, in terms of interparenchymal bleeding. So these aren't just concussions that are occurring in boxers. Boxers is a different breed too. Football is probably mostly concussions. All right, but will that cause problems long term? Sure. How many subdurals do you need? I don't know. One really bad one? We've certainly seen people with persistent cognitive deficits. And then, the dementing process or rather than a static process could be that there's some sort of cascade. I don't understand why that would be. It doesn't make sense. We haven't proven that yet. Or it's just a matter of other factors that would have been in play anyway, but now that you don't have that functional reserve in your brain, you're going to accelerate the process. All right, so, lots been written. I work with Ann McKee very closely. I like Ann a lot. Everything can't be named the McKee scale or the Omalu scale. All right? So it makes me, be a little concerned that there's a bias there. I also work with Dan Pearl at USIS, who was like the first guy. Now there's a Pearl scale. We need to stop naming scales. I think Cifu's kind of got a nice ring. We need to stop naming scales after ourselves and really just say, we're going to wait till we have a couple of 100 or 1,000 of these folks and study them over time before we start developing scales. In theory, the difference in CTE versus, let's say, Alzheimer's type dementia or vascular is that the first presentation tends to be more behavioral. They become a lot of paranoia, a lot of suicidality or homicidality. Now, if you've worked with folks that have develop Alzheimer's or have vascular dementia, sometimes their first presentation is a psychotic episode, so which certainly looks pretty angry to me and paranoid, but because they have Alzheimer's, like, well, he's just got Alzheimer's. But if you're a football player or a boxer and you get a little bit off, you do things a little more violently, perhaps. But perhaps it's a different pathology, because clearly they are seeing different. The autopsies are showing that it's not Alzheimer's. But now what we're seeing is actually there's a wide range. It's not just one type fits all. So there's some, neurofibrillary tangles, there's some tau, and it's in different locations. CTE is a real thing. Dementia pugilistica has been around since the 1920s. It's not novel, but now we're finding it more specifically. But it's not going to occur to anybody here. Nothing personal. I don't see any big-time athletes here. All right? I'm certainly not one. All right, maybe you played some college ball. All right, but realistically, nobody's getting it. We're good. All right, and it's not going to occur. Now, there are some NCAA players who are at a high level who have sort of made the NFL but then stopped because they were having symptoms. So it's possible they're having hundreds or thousands in college. But, 6 is nothing. I feel like a wuss, That's the other thing. Don't be a sports medicine doc unless you have a really firm handshake. I have one of the weakest handshakes a man can have, and I'm so threatened in the NHL. Really, it scares. I was telling Carmen, we won a game, and they almost killed me with the hugs and the bro slaps. It's crazy. Like, you got to be in shape just to shake people's hands in professional sports. I hate it. Anyway, it's real. It's rare. It isn't that useful clinically for your day-to-day practice to know about CTE. I mean, it's important you can tell the mom, your son's fine or your daughter's fine, okay? We're going to get her quickly back to activity the next day. We're not going to have them doing any contact sports until we reevaluate and they're able to play the sport. And the symptoms that he or she has are ones that either aren't there or we feel comfortable are not intracranial, which is all of them. But we're going to massage this. We're in no rush to get them back. On the other hand, we're not going to say that injury is going to ever cause CTE. We're not going to say that, oh, thank God we got it early, as it could have had a bleed. Or I wrote this chapter, second impact syndrome. Why did I write that? I don't know. I'm like, I've got so many calls on this. Like, I don't think it's real either. I don't know. I think if you get another bad brain injury, yeah, but 2 concussions, that doesn't make any. I mean, there's like 19 reported cases. Like, I have to write this freaking chapter. I just stole other people's stuff. But I get all these calls. I'm like, yeah, I guess bad things could happen. Yes. All right. But, let's worry about little Johnny's obesity more than what's in the brain. No, I got the brain thing. I'm all over it. But let's worry about the obesity. He's not cute. Really, he's huge. Okay? And we need to be working on aerobic conditioning. We need to be working on that. And so if you can use the opportunity to scare them a little, it's fine. But really, I tell the parents, come on. In my case, the parents are of these 19-year-old hockey players, but even the younger ones, let's get them back to the sport. Now, if Johnny isn't very good at the sport and doesn't have this drive, we could convert Johnny to like tennis, all right, or something that's still got aerobic conditioning. They don't have to go back to contact sports. I'm not a huge fan of that necessarily. Have you guys seen Friday Night Tykes on Netflix? See, I watch, all right, you have to see it. It's Texas. It's 7 to 8-year-olds playing football in Texas, in this league. 8 concussions, first episode. 8-year-olds. None of them, the coach is like, get up! What are you crying? Big bump, what are you crying? The kid's like seeing triple. What are you doing? You got to watch Friday Night Tykes. It's unbelievable. At the end of the first season, they had a sit down with the NFL neurologist, whatever the hell that was, and a couple of the coaches, and they're saying, yeah, this could be a problem. Yeah, I don't know. Everybody says, well, we're okay because little kids don't get a lot of concussions. It's okay. No, they do. You got to watch the show. It's crazy. And then the second season, same thing. It's like, this is, I didn't know this. I've got girls. I don't know boys. Friday Night Tykes, you got to see. It's insane. All right. Concussions are crazy. Playing, not like the next week, the next play in practice. Boom! Out! Back it up! Boom! It's this world. All right. So, because I talk a lot and the military likes me, they gave me a lot of money to study concussions. We've got a network of, we've got a network of 30 universities, 15 VA, 7 military sites, and we're looking at military-related concussions. We've got about 2,000 people enrolled in our longitudinal studies. We're going to follow them, so I'll have some more information next time. We're on year 3 of 5. We're now negotiating to get the next 5 years so we can study these folks long-term. We're looking for CTE. That's I feel like I'm in search of like Bigfoot, We're looking for CTE. That's our focus. Along the way, we're hopefully going to get somewhat of a longitudinal track of how these folks do, whether some interventions are having an effect, whether there's other factors, and there will be, of course, And we're about to launch another HBOT study. We got to talk about that because you can't do enough HBOT. Yes.
Once a year, how long after they have that potential concussion?
Yeah. Yeah. Very concerned.
Because it's such a bias.
Of course it is.
The majority of what we're seeing is 5 years, 10 years.
Yeah.
Putting in data.
8 months is our average. 8 months is our average for our longitudinal study. All right. And 8 months from the sentinel concussion. All the guys and gals have had concussions before. In youth sports, abuse, playing, in the military beforehand. But the one that we're marking has been 8 months, we're seeing, all right? Which is still too long, of course. But, we can't recruit them on the battlefield. That would be a goal. We now have a military site. We're trying to get them when they come back, but they're still 3 months out at the earliest.
And then any tied with financial?
Oh, no, they all do. Oh, no. They're all service connected. I mean, the ones that are VA. No, we've got that in there. Oh. Yeah, although you get, yeah, of course, although when folks have, no, we're studying your run-of-the-mill, and actually what we just did, we're an interim analysis, midterm analysis. We found that the folks that we're recruiting, who are 8 months or longer out, on average out, look the same as folks that are in the military before they've left the military, because we've got that data in terms of their symptoms, what medical issues, their physical questionnaires look the same. So these aren't the chronic VA guy that's coming to our clinic in the VA 8 years out and he's still complaining of pain out here, which is we can help that. We should be good at that. But these folks have jobs. They're part of the community, so they're not folks being recruited from the polytrauma system in a large site. I mean, they are, but that's not who we're getting. Yeah, and there's been a lot of literature looking at the impact of finances and benefits on them, and clearly there's an impact, but you can include that in your analyses, and that's not who we're recruiting predominantly. So, all right, so we're doing that. All right, so the answer is yeah, we need to better understand this. Always, I hate to ever say we need more research. Come on, we do. What we need to do is actually admit we don't know a lot. And we need to just stop doing things because. All right. What's the tool we talked about? The Exxon. What's the name of the one in the car? That new ultrasound guided shaving thing. 10X. Okay. 10X. I just heard a lecture on 10X. Okay. 10X is this make-believe kind of ultrasound knife thing that you trim something with. I don't know, cartilage or something with, right? So I just had a talk from a wonderful academician in orthopedics who went through this thing, talking about how he uses it to help people's knees and arthritis, and he shaves things, whatever that means. And I said, okay, but I'm pretty sure the literature is terrible on degenerative arthritis and the use of debridement. It's atrocious. He goes, oh yeah. Well, this technique is so far ahead of that one that we're still waiting for the research. All right, that's how good it is. I'm like, what? I said, don't use this make-believe thing, tech transfer thing you just came up with. Instead, let's wait for the research, then use it if it actually works. All right, which is kind of what we're doing. I think we need to be doing less harm. I need to be doing less harm, not you, but I need to be saying, we don't really know the answer to this. So part of it is let's do the same thing on each patient. Let's use clinical practice guidelines. Lisa was involved. I've led the charge to write 140-page clinical practice guidelines for the VA and the military. Nobody's read them except Lisa might have once by accident. But these exist. These clinical practice guidelines are out there. The folks out of, where was it? I guess it's Ontario. The folks in Canada that put it on, unbelievable. The Canadian clinical practice guidelines are amazing for concussion and for back pain. You got to use those. They blow mine away. All right, they're really, I didn't have Canadians to work with. You know, I had to work with what I got, you know. But you know, let's do things the same way. Let's be proactive. Let's think activity and exercise and return to normalcy is what the brain needs. Dark room therapy, which is inane, is stupid. I said it, all right? Dark room therapy for concussion for a kid? What? In a dark room. Well, that's what they did in the NHL until 5 years ago. The Panthers did it 2.5 years ago. I said, get him out of a dark room. He's a 20-year-old stallion. Get him running. Get him on the ice. He's been on the ice for 15 of those 20 years. He can skate with 1 foot backwards better than I can walk. All right? Get him out on the ice. You know, keep him safe, sure. All right? Get him in the gym. All right? Get him watching video. Get him becoming a hockey player or a student or a worker or a service member, again, rapidly. Dark room. Sit in a dark room for 2 days. Tell me how your cognition's doing. You know, tell me how your bladder's doing. You're going to be like, ridiculous. All right? So, you know, let's get people active. Let's always be doing standardized assessments. I'm not saying just wing it. All right? And I don't like impact, but it's the best we got. We don't need another tool. All right? It sucks, but the other ones suck worse. All right? It's okay to use it. All right? If you want to use your own homegrown, that's fine. Just use the same thing. All right? Well, what's the key to getting someone back after concussion? Be positive. Tell them their chance of getting well is crazy good. Now, it's tough to tell a guy 8 years out in the VA. I feel like an idiot saying this. Like, yeah, you got a great chance of good recovery. What? You know, no. You need to treat that like chronic pain. You know, so we're gonna manage your difficulties. We're gonna look to get you more productive and functional. We're gonna use MI to figure out what they want out of this. Motivational interviewing, you know, get them. You know, I get that. But you know, if they're within 6 weeks, please, come on. You know, if you know, we see a lot of kids in school at our sports center in DCU. We're like, please, Mom, he's gonna do great. Really. You know, I should do so well. All right? You know, be confident. I'm gonna be there. Our team's gonna manage him, but we're gonna get him back to activation rapidly, intensely. And if he has a flare of his symptoms, great. We can treat it. I love flares. It's fantastic. Life is a flare, you know? I'm in one right now. So we're gonna get them leveled out. All right. All right. So prevention's key. I'm not sure how to do that. Watch Friday Night Hikes. You'll see. All right. Not playing football, not having war, no more boxing. All right. You know, I'd be out of work. No, I think we still have some concussions. All right. So the myths, you know, they were self-explanatory to begin with, but you know, certainly if you get one really bad TBI, you can have chronic cognitive deficits. And you're going to be at elevated risk to get dementia, which has been demonstrated. Not the best studies ever, but Christine Yaffe's group has done a lot of work in San Francisco on that. Anyway, you know, I don't know how long after injury. I know a week is not right. I mean, God bless the Bible, but literally. But you know, I don't know that it would make sense to be exactly a week. Why not 6? Why not 8? Why not 0? I don't know the answer yet. But you know, you just use a standardized approach. Document clearly. Explain to parents. I've yet to meet a parent that doesn't totally buy into this. All right? You know, but, you know, if they don't, you got to work with them. I get that. Hopefully you'll see them before the neurologists do. Because the neurologists are like, forget it, man. 12 MRIs, dark room, and we'll do an EEG at some point. All right? I have great neurologists I work with. I'm teasing. But, you know, there are rehab docs that do that too. But, you know, and no neuropsych testing for at least 3 months, please. 90 days, please. Don't. It doesn't add anything. I love neuropsych. I got an army of them in my department. They're great. You don't need it for 3 months. Really. What are you going to do different? Nothing. All right. Now you can do some simple cognitive assessment if they're getting cognitive services. I get that, but not a full battery. Don't. Please. Lisa, no argument with that one? We're good? Okay. Bless you. Biomarkers, no. There's so much evidence-based stuff in concussion. Please, no more of that. Look at the CPGs. There's a lot. Are they massive longitudinal studies? No. It doesn't exist for almost anything. But, you know, the rehab world has got as many of these mediocre evidence-based studies as anybody. We don't follow them anyway. PRP has never been shown to work, and yet we do it like crazy. We do it in the Panthers. Sure. We inject every tendon. No idea why. We do. We did. And, you know, I got one yesterday. Ridiculous. We didn't talk about blast, but really no evidence that blast makes a difference inside the brain. I mean, if you're 2 inches away, yeah. But from a concussion standpoint, come on. The psychological factors I get, what your clinician response is, oh my God, it was a blast. Right? You know, like Stallone is up like in 2 seconds. You know, like he gets blasted every time. How come he can just, blood's pouring out of his nose, he's running around? Our blast guys, 12 years, you're going to be down. You know, it doesn't mean, if the blast gets inside the skull and you get brain melt, I get it. You know, Steven Spielberg kind of stuff. But otherwise, it's just the head moving. You know, and the military have these amazing super high speed, which probably are fake, but things where like the blast occurs, you don't see any movement. Then if you see it in super slow, have you seen these? Zoom, like that. It's a cat-like. Like, so their head is moving. And you couldn't see it. I don't know. I don't know if they were fake, but they look pretty good. And so those people had a concussion. I get it. If your head moves quickly, the brain doesn't really know what the force was that moved it. They used to believe 10 years ago I was at these meetings that the waves are going in the ears and the nose and in the mouth and belly button. Absurd. But it was really, they believed that. They were going to put like ear slings in and stuff, and it got inside the car somehow through the exhaust pipe or something. I don't know what they were talking about. But, if you're in a closed room or the blast is right there and you're thrown in the air, yeah, maybe. But going through the skull, I don't know, they have this sense of the pig skull deforms, and I'm not believing it big time. And other than one site in Seattle, nobody's really demonstrated any blast-specific differences. So I think that's it. Yes, thank you. I'll calm down. Questions? Comments? Yes? Oh, I love HBOT. It really isn't, but yeah. So just quickly, hyperbaric oxygen therapy, which Lisa really knows more than I do about it, is a fantastic modality for nothing. I don't think it even heals skin wounds. If you go back and look at the ulcer literature, it's terrible. Terrible. It works for the bends. But there's been 3 well-done studies, there's about to be a 4th, 3 well-done studies at the cost of $20 million, all right, that looked at the use of hyperbaric oxygen for 40 dives or exposures for people with persistent symptoms after concussion. These folks also had 75%, whatever the number was, of PTSD. And, there was a lovely sham, there was control groups in Lisa's study, and, other than the control group, who had absolutely nothing, anybody who got any intervention had the same outcome. So it's a wonderful, very expensive placebo, $20,000 for a 2-month treatment, $20,000. And the HBOT owners say you need to repeat it every 3 to 12 months for life. All right? I'm thinking writing a check would be much easier, right? So, really well-done studies. I helped design them, so at least. And great outcome measures, particularly in Denver. And really, you got nothing. Now, there's a caress of a suggestion that it might help some PTSD symptoms, unfortunately. This is my study. I don't know which one. So now, $15 million they're going to spend to look at another cohort of 180 to look at PTSD. Now, we looked at PTSD. We didn't see anything. And the slight improvement on 2 of the symptoms were so non-clinical. It's like, who cares? All right, but of course, the HBOT lobbyists, all right, believe it. And sadly, they've asked me to help coordinate it, all right? So I said, okay, we'll do it. All right, but really, I'm trying to fight it, but it's going to occur. So hyperbaric oxygen therapy has no indications for PTSD, for TBI, for any neurologic condition. It's been used for the last 50 years, however long oxygen has been around. It's been used for 50 years for every neurologic condition. Certainly in the pediatric world, it's been used for cerebral palsy. It's been used for, autism. I saw this one video. They showed a kid at age 3 or 7, or whatever, is getting it. Then they showed him at 16 sailing. Like, he looked like John Kennedy. I'm like, that's not even the same kid. But they said, there's Sergio sailing. It's like, that's not him. Like Sergio was like windswept and in like a full chair. And here he's like, I'm like, come on. I'm like, and they said, oh no, that's a miracle. I'm like, come on. So from my experience with a lot of folks with HBOT, no effect. The research doesn't support that. Danny, have you had any experience from a pediatric standpoint? Yeah, thank you. And even wound healing, I would no, it's got an FDA indication, whatever that means. But look up the literature on diabetic wounds and spinal cord wounds, right? Because it's used. There was about 70 referrals from the Tampa VA in the last 12 to 18 months for wound care outside of the VA. We just looked at that data. And if you look at the literature, and if you ask podiatrists in the VA system, they're like, doesn't work. All right. Now, what works for wound care? Everything and nothing, right? Just paying attention to it, Just turning them, just giving mindfulness to it, putting honey on it, Coke, whatever. As long as you're offloading and you're paying attention, you're changing the dressing. You know, HPOT, you got to do that in a big way. You know, everything comes off. They look at it once a day. So yeah, but it's a scary thing. But it's been a great meal ticket for me. And Lisa will tell you, I keep saying it doesn't work to every federal funding source, and they keep throwing money at me to do this. It's the best gig, really. But I don't even want to talk about HBOT anymore. But I will. Gonna get 10 more publications out of it. But yeah. Lisa, anything to add on HBOT? Your favorite? All right. Any other questions, comments, controversies? You don't have to believe what I say. It's cool. I don't believe half what. No, I do. I should believe it. And do you have any comments? Brain injury people? What's your experience? Oh.
You know, I think we're
Testing. No, interventions. Week 1, week 2. I mean, you know, yeah.
so that's, I think,
Yeah. Right. Oh no. Oh, I apologize if I can. Yeah, no. Oh no. We're counseling. I mean, I'm counseling 2 seconds later. Yeah. Yes. Totally down with. No. Totally agree with that. Yes. Thanks for that. Yeah. I mean, you can't treat them unless you know where they are. I get that. But in terms of doing a full battery, not only do you pollute the ability to do a battery again, you know, in 6 months, but also you're actually feeding in, I believe, you're feeding into the concept this kid's really bad. You know, I know the doctor said he was doing good and he was kind of jumping around. It sounded good, right? And he said, no, I'm all right. But he was getting this neuropsych battery for 3 hours, and Johnny's crying and has a headache. You know, so I don't. So that to me is one of the issues. What are your thoughts?
I think the assumption there is that the neuropsychologist is reinforcing brain injury.
Yeah.
When you're not doing that, I'm not doing that either.
Right.
Because I know the outcome of the treatment. I is a concern. So looking
Right.
at psychosocial factors.
Nice.
So 1 in 6 of our kids or our children.
Yeah. Totally. Yeah. Absolutely. The issue is, ain't a lot of people got resources like you've got, you know. And so if you send them to and we're pretty good. I mean, not as good as you guys, but if you send them to a community person who doesn't get that, man, you get a lot of pathology back. And you get a lovely report, which is dreck. But you know, and then the family's like, oh, he found all this stuff, and you know, no. Hopefully, you can train the folks that don't have quite that skill set. But I totally agree. You know, that's why the academic kind of world is a little bit different. Even where I am in Sunrise, Florida, we ain't got we have a neuropsychologist for the team, but otherwise we're dry, man. You know, and they end up going to like cuppers. You know, you got cognitive. I got all these guys with big cupping marks. And I'm like, that's not what I was thinking about. You know, but yeah. But cupping's very big in the NHL too. There's a woman in Atlanta who will fly to any of the team places for overnight to cup the guys, and they cup at one guy's house, and they all come over. I'm not kidding. It's like, really? And the next day, big blit. I'm like, great, that's good. That's gonna help. We use a leech to suck it out. Other questions, comments? Any other VA comments?
No, I was always interested in those. I feel like there often is potentially be a global study.
No, yeah. Very biased.
The bias that comes with it at times.
Yeah.
And then I see a second side of it where there's chronic kind of use of it where because the financial kind of is one that I look at.
Yeah. Well, one of the things the VA did early on, which was good, I think, and I'm obviously a big VA fan, so you can bash it if you like, but I think they're rocking. Not this Denver VA. Is they made the same payout. I meant the building, not you. The same payout, whether you get PTSD causing it or brain or TBI. It's the same check. So if you have a headache, it doesn't actually matter which caused it. You're getting the disability rating for the headache, all right? But you can also still get one for the PTSD even if the headache gets well. Now, I can say that to you. We get it. But, veterans are like, are you kidding me, Doc? Come on. You might be a really nice guy, but come on, they're not going to, so I get it, totally. Same thing true exists in the workers' comp world. That's it's probably worse than the VA said. And if you've seen one VA, you've seen one VA in terms of their ability. So it's a challenge, And sadly, Shinseki went down because of that. It's ridiculous. He was a dude. He was the longest acting, what is he? Secretary? No, what's it called? President. And what's Shinseki? Secretary, yeah, secretary, right? Secretary, yeah. Longest acting, and he went down because of the disability thing? Really? Really? The disability thing? So he was a good guy. I liked him. The new guy's kind of cool, too. So good. Thank you for putting up with me, and thank you for your time. I appreciate it. Go Panthers! We got a game tomorrow, I think. I don't know. I missed the game for you guys. Not really.